This is James Tatum from Muscle Driver USA, 2014 national champion in Olympic-style weightlifting.
And this is Travis Cooper, also from Muscle Driver USA, your 2013 national champion in Olympic-style weightlifting.
And you're listening to Muscle, Science, and Application.
Muscle performance and nutrition research reviewed daily. Real-world application tips, case studies from top professionals and athletes. You're listening to Muscle, Science, and Application.
Thanks for tuning in to Muscle Science and Application, brought to you by Barbell1.com. I have two very special guests on the show today. The man who cut me open so he and his partner in crime could put me back together. You guessed it, my guests today are my orthopedic surgeon and physical therapist who performed a successful surgery on my left hip back in April to repair my torn labrum and remove a large bone spur from my femur. My surgeon is a board-certified orthopedic surgeon specializing in femoroacetabular impingement surgery, which is a surgery I had, and many say he's one of the best in the country in this procedure. And working alongside him is my physical therapist, who brings a very unique perspective, having had FAI surgery herself. She holds a doctorate in physical therapy, has been practicing for almost 15 years. Today we're going to be touching on a variety of topics relating to hip health from the strength athlete's perspective, so it's my pleasure to welcome to the show Dr. Hugh West and Dr. Jenny Marland. How are you doing?
Thank you.
Thank you. Good morning, John.
Yeah, we're doing good. It's interesting. So when I was getting ready for surgery, family and friends would ask me, they'd say, do you like your surgeon? Do you feel comfortable with him? And Dr. West, you don't know this, but I would actually tell them, yeah, he's a good guy, but honestly, he seems a little cocky about the whole thing. I would say, but in a very good way. I said I'd much rather have someone, very confident performing the procedure than someone who seems unsure what they're doing. And it just seemed like it was a really, clear-cut case that I needed the surgery to move forward, and so that's what I did. And then Jenny has been great helping me with my therapy, and I progressed, had to try out some different things. And then I'd say the most important thing lately has been that internal rotation deficit that you were talking about on my left hip. Focusing on that has been really key to getting me closer to a full recovery. Sometimes I go into these things assuming that people have listened to all the episodes where I've talked about what I had going on and have kind of a prerequisite understanding. But for those that don't, kind of like the real quick and dirty overview, like the couple different types of common, FAI that go on, and kind of like what it is and how to tell the difference, kind of just very high-level layman's term explanation, I guess.
Well, a description of FAI, I guess we can do it best with just a simple little drawing of the pelvis. This is half of the pelvis, if you will. There's the socket. There's a ball that sits in the socket, femur. And the socket is a hemisphere that contains the ball. The classic, there's two versions of FAI. One is where the interference between the ball and the socket happens on the ball side, and the other version is where the problem is on the socket side. When it's on the ball or the femoral side, it's typically because the ball is not perfectly round. There should be sort of a relief where the ball turns into the neck of the femur. But in the case of femoral-based FAI, we call that a cam lesion because the shape looks like a cam, if people know what cams are. It's where you have a certain roundness, but that departs from round as it gets broader here. And so this extra bone here, as you try to rotate that into the socket, it doesn't fit well. And so it begins to put very high pressures on the cartilage. This is the cartilage that lines the socket. As that rolls into the socket, and very, very high forces, and it begins to soften this cartilage. The reason the labrum, we talk about the labrum so much, the labrum is a ring of cartilage around the edge of the socket, a soft sort of ring, O-ring if you will. And as this bone rotates into the socket, it essentially cleaves the labrum away from the bony edge, and we call that a tear of the labrum. But it's just that there's such a mismatch of fit between the ball and the socket that it begins to damage this cartilage. The problem is this cartilage is really, really important. It's where you pass all of the weight of your body through that every time you take a step or stand. And this is the critical cartilage. So as this begins to wear out, that usually corresponds with the onset of symptoms. So hips can be very durable and endure this shape for many, many years, but at some point it begins to break down, and we believe that correlates with you beginning to say, I can't do certain things. Mm-hmm. Now, the other version of FAI is based on the socket side, and it typically involves the socket being deeper than it should be. And the deep socket then basically bumps into the femur, and that can bruise the labrum and create symptoms that way. Usually it's just the labrum that's damaged there, because with a deep socket, the cartilage on the interior, the bearing surface is usually protected. So these are things we figure out or have to try to sort out. The femoral-sided FAI is more a male problem. We think that the acetabular-sided contribution is usually more of a female problem. But right. So that's sort of a quick and dirty sort of explanation. I think it's important to probably talk for a second about how we screen for this. It's one of the things that always, I will say, almost always accompanies FAI beginning to be a symptomatic problem is pain that's provoked in a certain position. And so Jenny is laying down on the exam table here. So John, you've noticed that when you were having hip problems, you lacked that flexibility in internal rotation. And when I saw you in the office, one of the first things we did was to assess that motion. So if we bring the hip into a 90-degree flexed position and we rotate the ankle out, that corresponds with internally rotating the hip. And that motion in people with your type of FAI, where it's more based on the femur, lack that motion. It comes to basically 0 or 5 degrees and it just doesn't go any farther. Whereas a normal hip will come out to 30 or 40 degrees of internal rotation. So that lack of motion is one issue that we look for that's classic for FAI. And then the other is how what hurts. And typically pain with straight flexion and then sort of urging the knee towards the midline is my hurting David risk. Is provocative of pain always. If we can't provoke pain by flexion and basically internally rotating the hip, then we are not thinking of FAI. We're not thinking of a hip problem primarily. So that very, very simple screening test captures the vast majority of people who really ought to be looking deeper with imaging, those kinds of things, x-rays, and trying to sort this out. So we call that flexion and internal rotation as a screening for a provocative pain kind of test.
So as we kind of talk about femoral acetabular impingement syndrome and all of that, I think for someone like myself, with the bodybuilding, powerlifting background, it can be tough sometimes when you're out there, you're doing your squats, you're doing your exercises and things, to be able to tell, is my range of motion, whatever it is it being limited by a lack of mobility or by a lack of actual bony space? So maybe you can tell us about how one would start to be able to understand what's going on there.
Yeah, good question. When you're not painful, obviously pain is a good indicator that, you're kind of bumping into more end ranges or tissues that are inflamed. But if you're not painful, some of the things, that you compensate for if you've moved past the normal hip joint motion and you're moving more with kind of excessive lordotic curve, pelvic rotation, movement, stuff like that, it is a little bit hard to tell and self-assess. So part of it is that it's a more firm feel. So when you're going down, you kind of feel like you can't go any farther. But when you push farther than that moment, sometimes that's when you go into more compensatory movement. But again, it can be a little difficult to self-assess.
Gotcha. And so how would you advise that someone determines what's a safe range of motion for them, particularly with, deep hip flexion and things?
Well, that's a bit complicated. We safe, if we assume that you're moving through motion without pain, then we don't get too concerned. But as far as safe motions, again, if you're lifting heavy weight and you're moving through movement that you can control with good core mobility, good core stability, good good strength where you're not exceeding and moving into using, like I said, faulty postures or compensatory movements, then we assume things are safe. But that's a very complex question. There's multiple factors that kind of go into that.
Sure. So this question is kind of for both of you. So if someone is, assuming, like you said, they have the appropriate prerequisite mobility, they're well warmed up, they know proper technique and things like that, and they're going to have a, career or athletic, longevity doing movements that involve deep hip flexion, what are your thoughts from a joint integrity perspective in terms of just, the pros and cons of getting down into deep full ranges of motion? Because obviously the usual benefit is both obviously to be able to express strength in a variety of movement patterns that you might encounter in sport, but then additionally also just simply allows more uniform development of the musculature. But in terms of a joint integrity perspective, what are kind of some of the pros and cons?
So you're comfortable.
Yeah, I was thinking, from a healthy, joint, and you're also talking about, two different issues here, whether you're talking skeletally immature, young athletes to individuals that are skeletally mature. But, we do say, when people come in and maybe early in symptoms, especially with evidence on x-rays of bony FAI, there can be kind of that large sort of cam morphology, that bucket of FAI with the large cam. And Dr. West often alludes to that as a hip at risk. And so I don't know if you kind of want to maybe touch on that. I think that's a little more.
I think our general advice is that if a joint is pain-free, we don't consider that there is any short-term or long-term risk implications to that. It's when symptoms arise that it does begin to prompt further sort of investigation into the cause of that. And sometimes it's just simple reuse, technique issues, balance strength. But there may be mechanical issues, structural issues that can impact. And that's where there's a fork in the road between just exercise advice and guidance and smart training versus we have a problem that we project forward and see further damage if you persist with these patterns of exercise.
Mm-hmm. And so FAI in general, I've noticed there's kind of a camp of people that think like, oh, it came from something you were born with, and a camp of people that say, oh, no, it has to do with, how active you were and you created this bone spur. And so I know myself, you always try and think back like, oh, gosh, like, what did I do to myself type thing. And then sometimes you're like, well, thanks a lot, Dad, and you just blame him kind of thing. So which is it, or what's kind of your opinions as to what are the predisposing factors?
Yeah, I guess this simple answer is we don't really know. We know that femoroacetabular impingement is basically an inappropriate mechanical interaction between the ball and the socket, based mainly on how it forms shape-wise. So we think of it essentially as the two not fitting well, and that tends to cause damage to particularly the cartilage of the hip, which is that important surface that we're trying to protect over the lifetime of the hip. It's the bearing surface. So we know that the shape associated with femoroacetabular impingement arises towards the end of skeletal maturity. So as you're starting to kind of finish growing and that final shape is beginning to be set, particularly on the ball side, you can have a shape that develops, and it has something, obviously it's a growth issue, and so it has something to do with the growth plate on the ball of the femur. It begins to develop an out-of-round shape, so to speak. And the socket now is a very nice hemisphere that can only accommodate a perfectly round and spherical ball. So any shape that departs from spherical becomes a problem in terms of load within the joint, especially at the end range of motion. And that's where you begin to get overloading of cartilage and progressive sort of damage. And it can be very slow or it can be more rapid. That's something we can't predict. But back to your question, are there risk factors for this? There is some evidence that there may be a link between level and intensity of activity in those developing years that relates to the development of FAI, but it's a weak link, and even if those shapes develop that put a hip at risk, it doesn't predict necessarily the appearance of symptoms. And so it always comes back to first symptoms, and then sort of a further investigation of what might be the cause of those.
Yeah, and you mentioned those kind of critical development years. What's the youngest person you've ever done this procedure on?
I think 13 years old. Yeah, and that's probably the young. Well, it could maybe happen a year younger, but it really, again, it's right towards the very end of skeletal development, and the earliest that people begin to sort of get to the end of that is usually about that age, 12 or 13. So we would not expect to see it any earlier than that.
Mm-hmm. And so it's interesting, as we were kind of learning more about my hip and I was learning more about the condition, we'd talk about how you could actually literally just go like survey a gym floor of people or kind of a random sample of people, and you'd probably find a certain amount that have either, a full-on, cam or pincer type shape, or maybe even something kind of along those lines looking towards that, but yet they don't seem to have any problems at all. What are your thoughts on kind of how some people seem to go asymptomatic and some people it just seems to be a problem right away?
That's a great question. Locally we have the University of Utah, and they did a study just a year or two ago where they went to the Huntsman Senior Games down in St. George, Utah. And what they did was they looked at a large group of people who were functioning at a very high level, and they x-rayed their hips to see if they had changes that were consistent with femoral acetabular impingement. And they found that a high percentage of them did. And that despite this, they were still functioning at a high level. They did. So there is a group that slips through that never ever really develops the symptoms or never feels limited by the problem. Another study that they did at the university was on their football players, and they said, okay, we're going to take these young guys who are obviously functioning at a very, very high level, and we're going to see if any of them have those X-ray changes that we see with femoral acetabular impingement. And they found that, shockingly, 95%, if you pick 5 or 6 things that sort of we define as FAI radiographically or with X-ray, 95% you can pick out at least one of those factors, and 70% two. So it just illustrates the fact that you can have these findings, but it does not mean you have a problem that we should be treating. It always has to be coupled with a symptom pattern that's consistent with the problem.
Mm-hmm. That's really interesting because I think even just in my own account, I've had some people be like, oh, that's ridiculous. There's no such thing as FAI. That's just a made-up condition and all this crap that people like to say. In my experience in interacting with both of you is that you were trying to air me away from the surgery as much as possible, and then ultimately we decided that was the appropriate choice. So how does one kind of respond to, I guess, those naysayers that say like, oh, it's just a matter of improving mobility, there's other things they need to work on, like ultimately for most people they really don't need the surgery. And again, I know you're trying to steer people down that path, but then like you said, sometimes you have to. How do you kind of balance all that?
Well, thanks for asking that question, because people need to know about this, not just the lay public, but even the medical community. The history of this problem, it really almost didn't have a label until about a decade ago. The term didn't really arise as a term of art in medicine until about 10 years ago. And that's a kind of a shocking fact when you think about all the people that, in your instance, for example, you would have started to have hip pain, and there would not have been a name for the problem, and your only option would have been to decrease your activity and sort of accommodate to it. So, in the adoption of sort of new information in medical practices is not a quick process. And a few years ago, someone did a study on this and said, so how many doctors does someone have to see before they get to somebody in the medical world that actually can speak meaningfully about the problem? And it turned out to be about 3.5 doctors before you got to somebody who talked to you about the problem. That means a lot of people are giving up. A lot of people are just saying, I guess I have a problem I have to live with. And there is skepticism even in the medical community about this. Whenever there's a new procedure, it looks like it's driven by industry. There's a certain sort of cynicism about new things many times. And even physicians who don't understand this problem can have that same sort of skeptical attitude. that this problem is kind of something we're kind of trying to make up or magnify. And so I think the only response to those kinds of sort of attitudes or opinions is education. And there's a rational, a reasonable and logical argument to discuss this, and it's a slow process though.
Mm-hmm. And Jenny, I think you bring a unique perspective in the sense that, obviously, you're not a surgeon, so people, again, that would make up all these things like, oh, they're just in it to, be cutting people open and do all these surgeries. In your case, you actually experienced the condition, so you kind of know firsthand, like, what it felt like and then, how you feel after. So maybe you can kind of share your perspective on how you educate people.
FAI, when you look at the, bony morphology and et cetera, I mean, this is why, it's a range. It's not a one, little bucket. There's variation within that, within acetabular and femoral and et cetera. But for me, I personally, kind of had a moment and then went years without actually experiencing any pain in my hip. I actually had mostly just knee pain and kind of generalized low back SI joint pain. And, that was also during the time when I, working as a physical therapist. So it was a bit confusing and difficult for me to even kind of navigate as the patient who works in the medical community. But once the symptoms became pretty isolated to the hip, it was kind of about the time where the condition was being a bit more discussed. So, for me, it was quite a few years between moment and when I had surgery. It was about 6 or 7. But for me, too, from a therapist hat, I look at people and there's some things and some reason to try, conservative, especially early on, when things are, not as symptomatic and not life-limiting. Certain patterns of motion or tightness or weakness or postural faults, we call them. You can see it often with weak abdominals and anterior tipping pelvic postures, which is kind of a bit of a tightness also in the hip flexor, and as a result on the gluteals and hamstrings you get more deconditioning, weakness, elongation of the hamstrings, and so that kind of position again can create some excessive loads and forces through the hip joint when you're moving and doing normal activities or even higher level stuff that can maybe even perpetuate or keep the hip in a painful place. So there's some need or to try things that are, good and conservative early on. But again, those things need to be done in a thoughtful way. And there's quite a few traditional kind of therapy styles and things or exercises we go to that tend to just make the hip more flared up. So it's also, hard to convince a patient when they come in here that we would like to see them try a little more conservative when they feel like they have seen multiple, physicians or, several other healthcare providers and have tried extensive therapy and stuff and never really been successful. So it's a fine line. Every patient is unique and different, and we try to make sure that when we're, looking at them and talking with them, with a collaborative approach, we can kind of offer something, individual still.
Gotcha. And I know in my case, actually, it was I guess, I don't know, it's weird, I thought to myself, like, was it a mistake, initially, this is what I thought, was it a mistake that I didn't get, second and third and fourth opinions and things, but again, I just felt really confident, Dr. West seemed really confident in what was going on, and I just, it seemed like the right decision, so, I had to move forward, been dealing with the problem for so long, but you kind of alluded to, you talked about that anterior pelvic tilt, some of the common things that you see go on, maybe either one of you can talk a little bit about kind of like some of the false alarms, so again, as you're trying to get to the bottom of the symptoms and figure out what's going on, some common things where it ends up, if you can just correct those, and it's like, oh, okay, you're fine, and you don't need the surgery.
So just some, differential diagnosis. I mean, we see there's a couple papers out there that talk about kind of athletic pubalgia, sports hernia stuff, and in symptoms similar, reported by the patient. But again, they can also happen and be happening together, so you can have them signs and symptoms of sports hernia and FAI in the hip joint, so not only in exclusion but together. Other things, generalized adductor strains, chronic groin strains, hip flexor strains. But you can also have kind of lumbar, referral patterns, so pain coming from the low back. Yeah, I mean, I know some of our patients have come in early, and like I said, even me personally, saying it was more knee pain initially and never really felt much in the hip.
I would say that FAI is a great masquerader in many ways of other problems, and we see people that get treatment for other problems, even surgical treatment, when the underlying primary issue is the hip itself. You can have pain that seems like hernia pain, low back pain, groin pain in the basically the adductors or the pubic symphysis region. All of these SI joint pain. All of these can seem like the primary problem when in fact they're compensatory problems. As you know, when you have at least femoral-based FAI, where the main problem is the shape of the femur, commonly you lack internal rotation of the hip. People just think they're not flexible, but it has to do more with a bony shape issue, which is not something that can be remedied by flexibility exercises. And yet you need that motion for many athletic activities. And the classic is the goalie in hockey who basically, that's the classic situation. They need that motion to do their job. And so you try to scavenge motion from other segments that aren't really meant to do that job. So you get a little bit of motion from the pubic symphysis, you get a little bit of motion from the SI joint, and you develop overuse problems that relate to those motions. And those present as the primary symptom many times. So it can be a distracting problem, that way. And, so I think it takes someone who is sort of, clued into that type of thing. Again, we've seen people that have had previous back surgery, previous hernia surgery, different procedures, when in fact they're not going to get better until you solve the problem.
Mm-hmm. And so how would you recommend, someone that's me, many, many months ago, and they're someone that's deep hip flexion a lot, they're, male athlete, strength training several times a week, they start getting that kind of pinchy, hitching, classic kind of FAI stuff in the front of the hip and the groin and stuff. Walk us through kind of like a series of steps they'd undergo when starting to feel that pain. Like, okay, first try this, that doesn't work, do this. Or if it does fix it, then you do this. Just kind of maybe a couple of scenarios.
Yeah, I think going back again to making sure, we're not talking about all FAI is the same. And Dr. West has mentioned a couple times the true CAM kind of morphology. And some patients, especially more females, tend to be more pincer-sided and not have, quite that CAM morphology. So, again, some of the things, when you're talking about limited motion or early kind of symptoms, people that have that loss of internal rotation, like Dr. West said, are not going to get it back by kind of stretching. So some of the things early is just rest, activity modification, just, trying to make sure that the tissues, are no longer being impinged. And, those can be simple things, of a period of time of resting. Again, stretching within comfort, modifications to different types of exercise, while you're taking a little time off, sometimes the anti-inflammatories, and then consulting, with a physician on, medications if those types of things aren't working. Sometimes steroids are helpful to kind of knock inflammation down. But, early on it's trying to, reduce the mechanical environment and try to reduce the inflammation. And so most of the time just pushing through and kind of continuing to work into those pinching, deep pinching, positions is not advisable.
So if you're, a bodybuilder, powerlifter, or someone that's strength training often, and you're getting into some of these, deep hip type movements, I found myself, it's interesting now, post-surgery, I seem to, I don't know if you want to call it more clearance or more comfortable or whatever, sometimes a little bit wider of a stance, sometimes maybe even out-toeing just a hair, whereas coming into the surgery, the odd thing to me was almost the only comfortable position was feet like right together, like, no width to my stance at all. Have you found, I'm sure it's probably different for anyone, but different patterns that are good kind of like workarounds when you're having someone do these kind of movements, either pre-surgery or post, that seem to kind of help facilitate a person being able to do certain movements more comfortably?
Going back to kind of the weightlifting world that you're discussing and kind of the deep squat, I mean, that's one of the things that, especially with the CAM FAI, that's a limitation, deep squat, especially kind of with that internal rotation moment. So again, like I said, positions where you can maybe, change the depth, and still, move through what is a pain-free range, or even kind of like you said, the toe position, is appropriate to kind of try. But as far as the, position of a deep squat, and especially in a cam type morphology, that's, creating or basically, that's the impinging position for that.
Mm-hmm.
Yeah, I think I would also add that in a young athlete, any that begins to develop hip pain, and that there are associated X-ray changes that seem to be suggesting the hip's at risk, it's a bad omen. I think once symptoms appear, the discussion begins that although there's no urgency to do something because the changes, the damage to the hip are very, very slow moving, we want to try to get people to wrap their head around the possibility that they're faced with managing their activity better to stay comfortable or doing something about the problem. And in fact, once symptoms appear, particularly in the younger individual, we're probably more worried than maybe the individual is in some ways, just because the damage can sometimes be out of proportion to the symptoms that a person has. So we worry that this will be put on the shelf and that we'll see people 5 years later with changes that we would regret, and that there's permanent damage to cartilage that will permanently cause symptoms that we can't remedy at that point. Again, I don't want to create a message that says that there's urgency to do this, because there's not. But I think that the strategy is, once symptoms arise, is kind of sit back and don't be too alarmed. Hopefully, possibly, this is something that's just an episode and that will pass. But that we're looking for the development of a pattern that's not changing over time. And if that takes 3 months or 6 months, that's fine. There's no big consequence for the hip. But we begin to worry that this is something that's going to be taken care of.
Mm-hmm. And as I was going through the physical therapy, we talked, Jenny, about say I'm doing that internal rotation hip stretch. I might do it with a larger or smaller amount of knee flexion, or I might do it with my hip flexed versus straight, and try a different bunch of positions, see what feels most comfortable. Try and loosen in a variety of positions. Create that mobility in a variety of positions. Have you noticed, again, any particular kind of like sweet spots, if you will, that work well, or even in the same way, someone's front squatting versus back squatting versus a different platform on a squat machine? I mean, again, I think all these things can contribute to someone finding motions that are still comfortable and allow them to train their body in a way that they want to and kind of work around things.
Yeah, I mean, I think, with at least, as far as the stretching and the joint motions and things like that regarding hip and knee, a lot of the muscles that cross the hip joint also cross the knee joint. And so, it is. I mean, you put the knee in a certain position to try to, accentuate a stretch of the hip, or kind of vice versa. So, we trial quite a few types of stretches, targeting one area with everybody, just because not everything works the same for each patient. So we basically get the position that works without causing the pinching pain or deep pain, sharp pains. And so that's, like I said, it's a bit of trial and error. There's no magic one sheet of exercises that works for everybody. So part of that is just kind of working through it together.
Right. And you mentioned, so I had come to you initially and was like, I'm not sure that the static stretching is quite as effective for me as I thought it was going to be. And I've been replicating a lot of those same motions with kind of like banded traction, and I seem to notice, things were working really well there. And you said that sometimes actually your male clients seem to respond a little better to more of those kind of oscillating, slightly shorter kind of movements, and sometimes female clients tend to respond a little better to more like static stretching. Maybe you can talk a little bit about how that is and how you help guide them on what's going to work best for them.
Yeah, so I think, keeping that within, that's just kind of our patients and our experience. But again, it's not across the board. There's often times early on where that static stretching is tolerated by most and quite appropriate. But we notice that sort of active, dynamic stretching, getting into kind of that lunge position. But again, you have to cue people well that we're not, again, missing the stretch at the same time. So the pelvic position is very key if you're trying to do active lunge stretching with hip flexor, that you posture correctly for the pelvis as well. But we find that it kind of works a little bit better when people just aren't responding well to just long hold stretching, static stretching. But again, I don't know if there's any rhyme or reason other than we try it and see what works. And
Gotcha. Fair enough. So how about just like in my case, my left hip kind of went, if you will, and I don't remember if we actually did the imaging on my right hip too, but I'm pretty sure we know that it's kind of doing the same, and yet, we didn't really need to have surgery because it wasn't bothering me so much. What are kind of your thoughts on that? Why is it always one hip that goes before the other? Do you ever operate on two at once? Like, how does that all kind of play out?
Yeah, that's an interesting question. If you're to look at the x-rays of both hips in the same person, generally they're fairly similar. Not always, but generally fairly similar. So it does beg the question, why would one become symptomatic and the other not? And we don't really know. I guess it goes along with the thought, what we were talking about before, that some people can live long, happy lives and have obvious FAI on x-ray, but never become symptomatic. We just know from experience that once one hip with x-ray changes that suggest the problem and are associated with symptoms and it's treated, we end up on the other side surgically about 30% of the time. And that means that the other people are doing fine. Mm-hmm. Even objective damage doesn't always correlate with symptoms. This is one of the problems that we see people frequently that come to us with MRIs of the hip that suggest labral tears. And yet the labral tear itself is not really contributing to their symptoms. And so all these problems need to be taken in context, and not just responding to what an x-ray says or other imaging.
Mm-hmm. And so one of the questions I had was, someone, they've had the MRI, right? They know that they have the labral tear, and is it pretty much all downhill from there? There's like no hope of recovering type thing, or are there some people that you have that get that kind of imaging and it sounds like maybe they actually do bounce back and don't need the surgery?
Well, it's not that straightforward because even there's complexity in terms of being able to trust the finding of the MRI. It's not infrequent for us to have an MRI interpretation by a radiologist that says tear of the labrum. And we frequently have the opportunity to look inside hips and compare what the MRI looks like to how it really looks visibly, and they don't match up many times. So labral tear diagnosis and prognosis don't always go together. We actually focus more on the bony issues when it comes to how we're going to solve the problem. There's also sort of a thought that, okay, I've been told I have a labral tear, so that's all that needs to be taken care of. But you need to understand also the labral tear, again, is a secondary problem to the primary problem, which is the bony pathology, the bony shape that's causing that soft tissue injury. So.
Mm-hmm. So, like in my case, like obviously we saw the imaging suggestive of labral tear, but it was more because the cam was so large, the extra bone there, that was kind of the raise for alarm, like it all connects kind of thing.
That's exactly right. That's exactly right.
Gotcha. So, imagine that someone is, I guess, trying to remedy the situation, and they're getting into certain movement patterns that, again, they're kind of testing the waters of how far they can go with various mobility and ranges and things. Like, do they always need to always avoid pain, or like what level of pain is kind of like okay to be experiencing as, again, you're in very, structured, careful motions trying to get your hip healthy?
I have a good speech for that now. We kind of feel like that if you're having, sharp pain, sharp kind of stabbing, not a little sort of achy sore, but those twinges, those sharp things that sort of grab you, if they happen repeatedly through the exercise and you stop and it's still continuing, and especially if it creates kind of lingering pain that lasts more than about an hour and a half, and over time, if you're continuing to have that pain and it starts to build where it's staying more of a constant nagging ache there when you wake up the next morning, those types of things where you feel like you have to take an ibuprofen or something, those types of pains are the things we say that's not what we want you to work through. It's the infrequent stuff that if you change position and it goes away that we're not too concerned about. Or whether it's not achy, sore, or lingering after the activity. But those are things you have to kind of be careful to walk the line.
I would also say it's also age relevant. Younger people, we worry more about pain in younger people than older people in many ways. In a younger person, pain, we project forward many decades, and pain is nature's way of telling us that there's damage at some level or inflammation at some level. And so I think in the younger person, we're more careful to respond to that, take that seriously. In the older person, there's wear and tear changes that inevitably accrue, and we accept a certain amount of that as we age. And if the older patient, is able to sort of keep that pain experience with activity in a certain equilibrium that is tolerable to them and doesn't seem to be a pattern of deterioration or increasing pain, then there's a certain amount of that we accept and don't worry about too much.
Mm-hmm. And one thing I've noticed a lot in the fitness community, there's a rise of people involved in CrossFit and, more people getting involved in Olympic weightlifting. They actually just had the national championships for Olympic weightlifting out here at the Grand America in Salt Lake. And with so many people becoming involved in these sports, I think it's awesome, to see people hitting the weights. But at the same point, I think some are very good at recognizing, proper movement patterns and, steering people away from and towards certain things and, getting prerequisite mobility in place before they do certain things and stuff like that. Have you noticed that with this trend of increased activity in these kind of sports that you're seeing the rate of FAI surgeries going up, that you would feel it's attributed to people like inappropriately getting involved in motions they're not ready for? Or if you're noticing surgeries go up, do you think it's more just simply just greater awareness and understanding of the condition?
I know we've had more people come in reporting pain onset after, beginning things like CrossFit or any kind of exercise program. And I think the key to that, though, at least one of the keys is that, if you begin something, especially for, early, as far as in life where maybe you haven't been very active and you're also motivated for kind of an exercise program as well, you're more vulnerable if you're not conditioned up to that activity. Just like any training, just like any sport, you have a progression through the years and as far as strength conditioning, et cetera. And so I think there's also some when you get into those things and you're not conditioned appropriately for core stability and not body aware and you're in those environments, you're more vulnerable. Doesn't mean that you will have issues or pain or problems with that activity, but that you're more susceptible to overuse or working outside of the normal range that you can control. And those, I think, are kind of key issues that way.
Gotcha. So with most things, it seems like it's always not so much the activity that's the problem, but again, being appropriately ready for the activity seems to always be the limiting factor. Can you think of anything that people do either maybe pre-diagnosis or once diagnosed, you're symptomatic FAI, like what people do that maybe is like well-intentioned and they think they're helping to kind of fix the problem or remedy the problem that sometimes is actually like the worst thing they could be doing and they just simply don't know it?
I think for FAI, and keeping it in the context of that, a lot of the stretches or exercises, if they're hurting and if they're making you worse, then those are not the ones you want to be doing. That's not the direction you want to go. There's a lot of ways to do or address mobility issues, flexibility issues, strength issues, things. And so, but if they're being done in a way that is just continuing to provoke pain, especially their regular pain, and making it worse, especially where you're achy and sore the rest of the day or the next day, it needs to be a different approach.
Yeah, I would question. You see physical therapists, for example, treating patients and using their benefit, their insurance benefit for these kinds of things that are not truthful, not useful.
Well, I think that strengthening of hip and core muscles or addressing mobility issues and things like that in weakness or tightness in a hip when it's not in the presence of painful or symptomatic FAI, there's certain exercises that are fine and you get away with those. But I think when you apply them in the symptomatic FAI patient, continuing to do those types of exercises or activities, especially when they're continuing to provoke pain or make the symptoms worse for periods of time after. I don't think that's good utilization of the visit. And I think that they need that the reassessment of the visit with the patient and the treating therapist to sit down and say, okay, can we look at things differently, try different things, but to continue to do that, treatment after treatment when the patient is, having increased pain and they're reproducing their pain, that's not a positive direction to go.
Mm-hmm. So listen to your body, as the old saying goes.
And important to speak up. I think also we hear a lot of patients coming in here and they say, yeah, I tried therapy, it made me worse. And I actually have asked a few people, I said, well, did you say anything? And they're like, no. So I think too, we have to, we have to speak up a little bit and make sure that we're communicating, what's working.
Yeah, no, that's awesome to hear. Because again, like I said, in my case, when I was starting to switch from the static to the banded traction stuff a little bit, I did kind of feel like, oh gosh, like, am I supposed to say something? Like, and then only to find out, like, oh yeah, a lot of my male patients do respond to that. You're like, oh, okay, it's okay to talk about these things. So I'm glad you brought that up. One thing that's kind of cool about this show being listened to currently in 162 countries, believe it or not, is that once in a while I'll have people write to me from another country. And so a listener, Daniel from Australia, writes, and he actually recently had the surgery where they had to fracture his femur. And so maybe Dr. West, you can talk about this, and feel free to even grab the whiteboard or anything if you want to. But we're kind of circling a little back. Some of the listeners have heard me talk about my condition enough to where I think they kind of understand FAI, but maybe you can give us the real quick and dirty, like layman's terms, overview of kind of the different types of FAI, and then when or when not the femur fracture would be appropriate, because that was actually something he was wondering. Like, he's like, I can't go back now, but like, was that the best choice for me, kind of thing?
I'm not exactly sure what condition we're talking about as he talks about fracturing the femur. I will say that with FAI, fracturing the femur to create a different anatomic shape is not something that's part of classic FAI treatment. It usually refers to other problems that relate to developmental growth issues that actually happen earlier in life, where the socket doesn't form well and the relationship between the femur and the socket needs to be remedied by actually changing angles and coverage and things like that. I believe he's probably referring to a different set of problems that's not actually what we're talking about here, FAI. More of a dysplasia type of sort of spectrum of problems. There is, interestingly enough, a risk of fracture with the treatment of classic FAI. You can remove too much bone, and actually, as you're trying to make that shape fit better, where there's not enough structural bone to support the weight of the patient, and the femoral neck, where that bone is removed from, can fracture. It's a rare complication. It's something that we are certainly alert to. Something we've not seen at this point, but it's something that's in our mind as we are removing bones to shape things.
The best case scenario you've ever seen of someone recovering from FAI, and kind of like the worst case scenario, maybe any thoughts on like kind of why that was, just as someone is kind of trying to get a better understanding of, again, people usually like to know kind of worst, best case scenario type thing.
Yeah. People that do well, obviously they have the symptoms that are appropriate. They have the workup that's appropriate. Everything makes sense. They're young and active, healthy, fit, and don't have a lot of other confounding issues, long-standing low back pain and other things that sort of contribute to slower or potentially, kind of a delayed recovery. The other thing, is there's other factors, that play into it. But again, for the most part, the majority of our patients do quite well.
Yeah, John, at the beginning of the interview, you said that we seemed confident, and maybe overly confident.
Wasn't a bad comment at all.
Yeah, well, in medicine, there's a lot of gray, obviously, and so we're always sort of relieved when things are more black and white. And a young male that's active, well-conditioned, and has clear-cut changes on X-ray that suggest FAI, we feel very confident in suggesting that we have a solution for you that's going to be a very high probability of a good outcome. That's not the case in all patients, and we spend our days sort of scratching our chin and wringing our hands over, can we help someone? Is this a is risk outweigh the benefit or vice versa. We always worry about young, very flexible females, even though they can have changes on MR and imaging and X-ray that suggest FAI. We're still much more reluctant to embark on surgical treatment because it's a longer, more protracted recovery, and the results generally tend to be not as good. Not that they're not improved, but they're just not as slam dunk as perhaps the young male like you is. So we have people who are just astounded at how quickly they recover and how quickly they get back to activity without symptoms. And we have a group of patients that will always be our patients because we probably will always struggle. So, and that's hard. That's hard for everybody. So this is, when people, again, have a certain criticism in some cases of surgeons making decisions that are too liberal. We feel quite humble about our lack of complete understanding of these problems. Realize that it's still in its infancy in many ways. It's evolving quickly. We feel privileged to be part of the discussion. Doing enough of this, I think, to have some experience that's relevant and contributes. But by no means is it figured out yet. But it's marvelous that we have something to offer. You think of all the people that over the history of mankind have developed these kinds of hip problems quite early in life many times, and how that relative disability really impacts their quality of life for the duration of their lives. And so it's very satisfying for us to be involved in a new art that actually has something to offer. We feel very well.
Nice. That's cool. And I actually can remember waking up from the surgery and just kind of thinking, like, that must be a cool feeling, like being on your side of kind of like, hey, like, this person's probably going to be able to move forward pain-free and, get back to life as usual. And
yeah,
I'm getting damn close right now, so I'm excited.
Well, I know, John, too. I mean, you experienced it, but we have a pretty integrated team approach. And so, there's, a lot of opportunity at the beginning, especially embarking on the surgery, to sit down and go through expectations. We do, keep close track of how our patients do. And so, we feel like setting those expectations pretty clearly, before surgery really helps on the backside. So at least in your experience, we're pretty confident based on all the patients we've seen and encountered and treated and helped. But, like you said, not everybody is going to fit into that box, and so it's really important to go in eyes wide open and kind of set that clear expectation so the patient is not disappointed when the person next to them maybe had it or on the internet had it and got back to doing this and that, and they're still struggling. So.
Gotcha. Well, I know in my case, I commented within like 2 hours after the surgery, I'm like, I'm in less pain now than I've been the last 10 months. So I guess I was one of the good scenarios. And again, like I said, working hard on that left hip internal rotation currently and seeing some headway, seeing the light at the end of the tunnel. So I want to thank you both again for coming on, giving us your time. I know, Jenny, you got to get to a patient, but thanks again. All the best, and maybe we'll chat with you some other time. Hopefully I don't have to come back in for the right hip.
Good luck.
Good. Thanks, John. Good to talk to you.
Bye-bye.
Thanks, you too. Bye.
Thanks for listening to Muscle, Science and Application. We'll be back tomorrow. If you enjoyed this episode, please leave us a review on iTunes. Find us at appliedmusclescience.com.